Hi, this is Elliot Fishman, and welcome to our latest Facebook Live. Today's a bad hair day. I tried not to dry my hair or anything, and now kind of like screwed up. But anyway, hey, got hair. So this is on cardiac CTA, and just wanted to thank everyone first who came out to the Lust Garden Walk last Sunday. There's another walk for Lust Garden in Annapolis when it's probably going to be a lot cooler on September 8th. So that's probably a great place to be. Now, cardiac CTA, I thought I would just go through a few different things. So I guess by a show of hands, how many of you are doing cardiac CTA? And the answer would be not everybody. I think the one thing you can do that is reimbursed, that's very easy to do, and if you're not doing cardiac CT, as long as you have a decent scanner, is reasonable to do, and that's calcium scoring. And calcium scoring, very quick study. At Hopkins, some insurance companies now cover it, but most of the time they don't, and patients pay out of pocket, and we charge $75. So I guess we make a couple bucks. The word would be a couple, if anything. So it's kind of more of a service to the referring docs, from the internists. A lot of the internists, and I think this is a little bit related to where you are, a lot of the internists in some cities like Baltimore seem now to be wanting to get calcium scores in their patients for a baseline. And that's probably a good thing. You ask what age, probably age 50, but remember with calcium scoring, it never lowers your risk, it increases your risk. So if you're not sure to give someone statins, do a calcium score and the score is elevated, then you could really justify giving statins. If the score is 0, family history is high, you should be treating the patient anyway. So the calcium score is important, particularly in patients without other risk factors, because you never use calcium score to lower your risk profile. And that's a very important thing to remember. So that's kind of a good thing to think about in that regard. Now, the other thing becomes, what do you do with cardiac CTA? So ideally, you would like to say you're doing it 24/7, 365, but that's not that easy. It's a combination of getting great technologists who know how to do cardiac CTs, as well as the ability for radiologists to be available to read. We do it till 7 o'clock, 7 to 7, so 12 hours. And that may be as a common thing, though some people don't do it on the weekends. We do a reasonable number of cardiac CTs by themselves, which is a cardiac CTA. We do that from the ER patients. We do that from patients coming from the cardiologist's office with chest pain. We also do lots of work with trials. Dr. Lai's been looking at AIDS patients and patients who have IV drug abuse and minority patients in the inner city, looking if cardiac CTA can help with early detection of heart disease and intervention based on that. So, and there's been some work published on that by Dr. Lai, but it is one of the reasons for doing it. And then at Hopkins, we also do a lot of triple rule-outs. Remember, triple rule-outs rule out coronary artery disease, rule out pulmonary embolism, rule out dissection. Now, I will say that from a perspective of doing a study, the triple rule-outs are the hardest, right? Because the timing that's good for PE is really 15 seconds before or so what's good for a coronary or an aortic root. So there is this trying to get the best study where everything's opacified, but there's no artifact, and you can get a good PE study and a good aortic study as well as get a good coronary arteries. You can't be in a situation where you get a great PE study because it's early, but you don't see the coronaries well and you don't see the aorta well, and you can't be so late that you see the aorta, maybe the coronaries, but you have no idea what's going on in the pulmonary arteries. So usually it takes a little bit longer delay, a little bit more contrast, and you need to be experienced with timing it. I think that's really the issue. And we haven't spoken about this topic in a while, doing triple rule-outs, but in the right population, it's good. I will have to admit, triple rule-outs, remember the surgeon, the ER doc or the PA, they're not certain whether it's coronary disease, aortic disease, or pulmonary embolism. It's interesting to me how frequently those studies are negative because you're not sure of what's going on, and often nothing's going on. If you look back, the number of positive PEs you find are almost non-existent. You do pick up some dissections occasionally, and occasionally have coronary artery disease. But in my experience, and this has been published not by us, but by other people, that patients with triple rule-outs basically end up often with triple negative, even in the face of a good study. So triple rule outs have higher dose, take a little bit more time to read because there's more images, and they're a good study for certain population. You don't want to be in a situation where you're doing triple rule outs on everybody. That's really not what you want to be doing. So we spoke a little bit about triple rule outs there. We spoke about calcium scoring. And again, to remind people that calcium scoring, some of the software being developed now by companies will do calcium scoring on non-gated CTs and get a pretty reasonable guesstimation. Because remember, whether your score is 120 or 160, it's not really going to matter. What matters is 0 to 50. It's just anything but 0. And so at least you can scale it. It's important for radiologists, and we've said this before in some lectures. I hope we've said it at least, that it's important for people to look, when you're looking at the heart, regardless of the application, to comment in the coronary arteries. There was an article a few years ago that showed that radiologists tend not to comment on the coronary artery calcification. And a patient with chest pain, coronary artery calcification, in the absence of coronary artery visualization, would make you think the patient has coronary disease, and perhaps that's the source of the pain. So in that regard, I think it's a good idea, but you need to mention it. You're not going to say, well, the score is 136, but you might say minimal calcification, mild, moderate, extensive. And then people can go from there. And we all know that, particularly in older patients, we will pick up a lot of calcification. Doesn't mean they have stenosis, but they have a lot of calcification. But in many of those patients who are not under cardiac care, that would be an ideal thing to do. So I think that's something to indeed think about. Now, the other thing with coronary CTA is trying to figure out how to read the studies. I think the reading is really all dependent on the acquisition. If you have a really good acquisition, so we like to have the heart rate below 70, even with fast scanners. A heart rate and a steady heart rate is critical. Metoprolol lowers the heart rate and improves the beat-to-beat differentiation by minimizing it. So I think in those scenarios, even if you have a very fast scanner, some people will feel, and rightly so, that giving something like metoprolol, which lowers the heart rate, is a good thing to do because, patients may get nervous, the heart rate could go up, but also the chance of you getting a good study with 10 metoprolol waiting 30 minutes is really going to be a lot higher. 50 metoprolol is going to be a lot higher. Now, patients who have really high heart rates will sometimes give 100 metoprolol. But again, you want to manage and streamline things to your individual patient. I think in terms of analysis, you need to have some software. We do 3D, MPR, curve planar reconstructions. We analyze all of the vessels. We segment them out, stretch them out, elongate them, analyze them, evaluate them, and then send a report about them. So we tend to be fairly comprehensive on this. I think that's very important. Now, people do look at functional reserve in the coronary arteries. And there's a couple of companies. Artis is the one most people think about. You can send them your data, and they could do a lot of calculations based on your coronary CTA. The challenge, of course, is it's probably $400 or more. And who's paying for it? Because the patient has it approved. So you would have to choose to send it up to the cloud. They would do it, and then you would get the results back. There's a lot of good articles on functional flow reserve, and it may be something that's coming along. I think the biggest challenge is going to be the reimbursement. Who's going to pay for it? But it does have pretty good results in the published literature. So we'll have to see what happens there. Ravidra Rakari from India wants us to comment on pediatric patients. I think pediatric patients are the most difficult when you're trying to look for different pathologies in the coronaries or in the aorta or in the heart. One thing we realize is kids have very fast heart rate, but you want to do the studies where everything's opacified. It's very easy to be too early. So you want everything opacified. So maybe a little more contrast and waiting a touch longer works well. I think you want the arterial and venous structures to be opacified. You look for fistulas then, you look for PDAs, you look for a lot of things, but the biggest danger in the peds is not having enough contrast. So ideally, you would want to have good opacification. A CTA works very well for newborns. Obviously, the heart rate is high, at least 120. And you got to be thinking about what are you worrying about. If you're worrying about tetralogy, if you're worrying about coarctation, if you're worried about transposition, I mean, any things you can think about where abnormal pulmonary venous return, anything you can think about where coronal views may help and 3D may help with visualization, I think it's really good. We can lower the dose in PEDS patients. And particularly these patients are really very problematic when you don't know exactly what anomaly or what's going on. And then you could really build on that. And that becomes very important because there's a large population of people that will present, and you can get used to that presentation and really get the information on that. I think things like pediatric cardiac CT will benefit from AI for analyzing the flow, analyzing the various chambers, size, and looking at flow and flow direction. So that's something that AI will be really good at. And we are working obviously in pancreas, but we're looking at other things that relate to vascular structures. That indeed will be important. So let's see, we're at the 11-minute mark, which means it's good if you have any questions to ask them. And John Biacchino's in the Magic Kingdom. I think he's been to the Magic Kingdom more times than Mickey Mouse has. So we'll say hi to John down south. So that's kind of a cool place to be. Probably is not cool. Probably it's like 90 degrees with 100% humidity. Florida has this way of being super hot and super humid in the summer, and you particularly know that if you wear glasses, because if I get out of an air-conditioned car, I kind of can't see for a few minutes because my glasses fog up. And if you're not in an air-conditioned car, you're sweating and your glasses fog up. So I think they call Florida the foggy state or something like that for that reason. But let's see what else I can tell you. Coronary CTAs, the post-processing becomes very critical. You need good data acquisitions, good timing. The patient needs to be spoken to during the study. That is the biggest problem with cardiac CTA, as with many studies, is patients not holding their breath perfectly. You need to make sure you and the patient are in communication, not just all of a sudden say, hold your breath. Patient gets scared, they don't hold their breath. You got to say is, hey, I'm speaking, we're going to get started now. I'm speaking to you. You ready? We're going to count to 3, then we're going to start, press the button. You'll hear the noise, the scanner will come on, and then we'll be done. So you need to be really communicating with people. If you're not communicating, the people aren't happy. So that becomes very, very important. And Heidi Ann says it's hot in New Orleans. I wouldn't have guessed otherwise, but hi, Heidi. What else can I tell you? In terms of cardiac CTs, people ask about ejection rates. We're going at 5 to 6 cc's a second. The catheters we use are easily tolerate them at a 20 and usually at a 22. That becomes very important because before you needed a 15 for a catheter, and that's just hard to do, or at 18, 15 was ideal. We never did 15s, we did 18s. But for a lot of patients, 18-gauge catheters are really, really hard to do, so hard to find the vein. Well, let's see what else. Post-processing of cardiac, every vendor has a different way of doing it. We have Siemens, so we're doing curved planar reconstructions along the various vessels, rotating them, looking at origin, looking at the end of the vessel, and looking at that for each of the vessels. It's a very systematic plan of how you review the coronary arteries, and then you can speak to the patient. But again, it's important that if you don't have a lot of experience, it can be challenging to do these studies, particularly if the patient has calcium. It's been shown that people with more experience can do better, especially on difficult cases where the computer doesn't know what to do. So it's things like that where people with experience are much better. There was an article that spoke about calcium scores above 1,000. You should not do cardiac CTAs. Sometimes that's indeed true, but most of the time it's okay, but you need to know the limitations of where you can't cause stenosis. And the fact is it's more difficult. But being difficult is not the same thing as not doing it. So I think that's one of the things. And I think, it's interesting, just finishing up here, today is the 15th on a Thursday, and the 15th of August. So some of you may remember, or some of you may have heard, that today is the first day of Woodstock. So what do we do for the first day of Woodstock? We can run around like we're in Woodstock, but I think it just shows how time has flied and how changes occurred in 50 years. Think about what CT scanners were 50 years ago in the past. And I doubt there's anybody who's going to say 50 years from now, they're not going to be here. Their role may change, but they're going to be here. And in cardiac CT, I think we are doing a reasonable number of studies now. I think the key is making sure you call your referring doc, making sure you poo-poo the technology. And then I think moving forward, you're going to do a great job. So with that, I'll say hello to John again. Have a great time, John, in the Magic Kingdom. And for the rest of you, have a great time wherever you are. Have a great day. Bye.